shared decision making. It's just not the kind where, let me tell you what the options are for your situation and the pros and cons of each one. And now let's go through a deliberative process to figure out what are your values and preferences and try to match them to uncover what is needed. Yeah, of course, nobody does that. But if you think of the nurses in the hospital that are working with patients and families to figure out the discharge process, when are you going to go home? And will the conditions at home be ready for you? And let's make sure that that's the case. That is shared decision making, and it happens multiple times a day in every ward, most wards, in most hospitals, that are somewhat focused on making sure that you're not putting people on the street as you discharge them. So shared decision making is potentially more common. Sometimes it is helped by tools. That's a QR code where you can go and explore some of the tools that we've developed over the last almost 20 years, with conducting clinical trials to figure out what they would do. Examples of this is the first one we did. This is the statin choice decision aid, helpful to communicate complex figures. In this case, on the left, that is the patient's risk of atherosclerotic events. On the right is how that risk will be reduced by statins. And so you'll use things like you're in a room with 100 people like you. If you were to do nothing, 21 of those people like you in the next 10 years will have a problem, a heart problem, and the other 79 will not. I do not know if you're one of the 79 or one of the 21, which is the biggest uncertainty. I mean, forget confidence intervals, and the biggest uncertainty is, am I one of the green ones or one of the orange ones? And then if all 100 were to take a statin every day for the next 10 years, what will happen with these 100 people? That's on the right. Once again, I do not know if you're one of the green ones, one of the blue ones, or one of the orange ones. A different conversation than, your LDL cholesterol is 101 milligrams per deciliter. The American College of Cardiology has recommended that we drop that to less than 100, in fact, less than 70. Why not less than 50? Let's make it undetectable levels of LDL cholesterol so that you can live forever. Completely different conversation. This is a different kind of tool. This is to select diabetes medications. Now, I'm showing you this one because I think this is probably the most important work we've ever done. It has nothing to do with diabetes or shared decision making. It has to do with making choices in your life. Sometimes you have a lot of options, right? And so here's a lot of options on the left. The natural tendency of people is to start with the options and say, pioglitazone. You take a pill every day. When you take it, you might get some fluid buildup. You may gain weight. It doesn't give you low blood sugar. It reduces your A1C by 1% or more. It may or may not contribute to reducing the risk of peripheral vascular events or amputations. Metformin. It might, weight neutral. You take it once or twice a day. It's very cheap. And so you start. Now the person that you're trying to help has to keep all the information you gave them about pioglitazone while you're giving them now the information about metformin, and in their head compare the two in real time. And wait, there's more. Here is sulfonylureas, and on top of that you're using those words. Right? And so the thing that we uncover with this is that we don't start with the options, we start with the issues. And you ask patients, what issue would you like to discuss first? Of the ones on the top, which seems to be more relevant to you at this point? So the patient may want to say, well, how do you take this stuff? And they might see a list where it shows that some are pills and some are injectables. Oh, I prefer not injectables, I prefer pills. Okay, so there's a few pills there. What do you want to know about those pills? Well, I would like to know if they're going to help me lose weight. Well, it looks like one of them, there is a pill that at the bottom, SGLT2 inhibitors, that's going to help you lose some weight. Oh, I'm interested in that. Okay, let's discuss that. And now you're basically going through all the other features of that one. Is that okay? Well, let's try that out. You know what happens if it's not okay? You go back and try the next one. And it's very quick. And you don't have to feel like, oh, but I never told him about insulin. Shared decision making is not just about the disposition to care and be interested in what this person needs and wants, but it's also about creating an environment for care, for those unhurried conversations. One in which you will not be disrupted, interrupted. There will be no distractions, if at all possible. Maybe you have people trained using tools. That's a good-looking guy there, very young. I know you cannot recognize me in the picture. I understand that. Yeah. And then in the clinical trials that we have, I would like to highlight two outcomes of interest. These are all the outcomes that we summarizing here, all that experience.
But there are two that are quite interesting. One is, when we started this, clinicians were a barrier to involving patients in decision making. Yet in our studies, when you design things that contribute to the work that patient and clinician are trying to do together, and you design for them, what you get is something completely different. The most consistent finding in our studies is an improvement in clinician satisfaction. An improvement in clinician satisfaction. And the other one is what's on the bottom, is that it doesn't take more time. So how can it not take more time? And yes, it takes more time to put one of those tools and be very deliberate about it, stuff like that. But as I told you, the majority of shared decision-making interactions are replacing the conversation that is happening anyway. But instead of the LDL cholesterol is 101 milligrams per deciliter, and instead of that, you're doing this. And on average, the time is the same. I emphasize the on average because when you watch these videos, you often recognize that when you're opening up the opportunity for conversation, for many patients, it is the first time. It is the first time that they're feeling seen, heard, understood, cared. And then the material facts of the choice become completely secondary to the fact that you're generating a relationship that will allow you, give you the resilience to recover from the wrong choice, so to speak. Another aspect of this is, forget this. This is not a helpful level. You do not have a way of working through these diagnoses. So stop labeling people with this or all its more acceptable derivatives like non-adherence or what is the other one, collaborative, whatever, right? Don't label the patient, label the situation. This patient is in a situation of an imbalance of workload and capacity. That's like, that's like heart failure, that's like imbalance of workload and capacity. And immediately you can begin to think of ways of improving her situation. If you understand the work, we've described that, and where the capacity lies. And these are all sources of capacity, right? A sense of purpose, resilience, literacy. Literacy not like, can you understand my handwriting? Or can you understand the signs in the hospital? But literacy, the next level literacy, which for patients with chronic conditions is critical, which is, here's the instructions. I should be taking this on an empty stomach, but I just took that other pill. Does that still count like an empty stomach? It's noon. I was supposed to take it in the morning. Is this one of those pills that I can still take in the morning, or should I just skip the whole day? The notion of becoming able to say, when am I going to take exception of the rules as written because I know it will be okay? Literacy towards mastery. Health capacity. If you have a bad knee, it's going to take you a long time to get to that bus. So you'll schedule fewer things in the day because you know you have to move a lot slower. If you're depressed, you'll be walking through molasses. You may not be willing or able to get out of bed. And so this will reduce your ability to do the work. Financial health. It takes a long time to be poor. Because you can't really pay other people to do anything else. You have to do it. You are the capacity that you have. And particularly social isolation and an inability to ask others for help. We'll come back to that later when we talk a little more about the pandemic. So what could we do to reduce the workload? We can prioritize the treatment through shared decision making. We can use the platinum rule, not the golden rule, but the platinum rule. Do unto others the way they would like done unto themselves. Right? Which requires you to be curious and understand who is this person, what makes them famous, what matters to them. What are their social and personal circumstances? We need to have a ban on medical errands. There are a lot of meetings where people go, wow, I wonder how we're going to find that information. Let's ask the patients. Let's do a survey. We'll put it on the iPad. They'll click. And with no understanding of all the other stuff that we're already asking patients to do. We don't know if your insurance covers that. Why don't you call them? Because, our administrative assistants are too busy. You call them. You be on hold. There's actually a great story about Google developing a bot that allows your office to call the insurance company to argue your case for a pre-authorization denial. And then some other company selling another bot that answers on the other side, the bot that calls in for the lean consumption, right? So a number of organizations are interested in lean, reducing waste in our healthcare delivery system. But we have to go further and make sure that the efforts continue outside the hospital door so that we try to reduce the waste on patients' time, effort, attention. It's very limited by illness. So we have to be extremely respectful. That's what I mean by kind care. It's not only being able to see the other person as a member of our kin, but it also means understanding that people have very limited energy, time, and attention, and we cannot waste it simply because, well, you're sick. What else is important to you? And then when we're going through this digital transformation, we need to make sure that the digital transformation doesn't, in an unintended fashion, introduce a number of new tasks that patients have to learn in order to be able to talk to you or call you or get access to the treatment that they need. Now they have not only administrative barriers, but also technological barriers. And I'm not talking about old people not able to use their computers. My mom is more than 80 years old, and she spends almost all her day playing video games. That's not the point, right? It's the point that these are new devices. I have a colleague that works for a large corporation who tells me that every employee has wellness apps on their phone. They have an app for anxiety. They have an app for depression. So the employee has to figure out, is what I'm feeling depression or anxiety? Because otherwise I'll be in the wrong app. Capacity coaching is a new form of health coaching that is effective in bringing up capacity, self-management, education, and training early in the career, in people's illness career is potentially helpful to develop that literacy and that mastery. Palliative care is not just for people who are dying. A lot of our patients have limited capacity because they're short of breath, because they're in pain, because they're not sleeping. And we can help with those symptoms to try to give them more capacity, not so that they can be better patients, so that they can have enough capacity to do the patient stuff and live their lives. It's the living their lives part that actually is the important bit. Psychotherapy, physical therapy, occupational therapy, trying to get whatever function they have going so they have more capacity. Social work, mobilizing the assets in the community that can help patients do better. An international group published a manifesto on making care fit. How do we make care fit this person? And it has this incredible line. Patients and clinicians must collaborate in designing care plans that maximally respond to each patient's unique situation and priorities while minimally disrupting their lives and their loves. That's the job. That's the job. This is a great picture I got on Twitter. I have no idea where this is. But people just got tired of waiting in line. They put their shoes instead and have a sat down. So it doesn't matter how much you make your own programs of care fit if your institution is actively telling people, your time is not important to us. Stand in line forever. So there are other things that organizations can do in addition to recognize that the main purpose of their existence is not to use cool tools and gadgets. It's about care. And the second thing they can do is they might want to try some principles of Darwinian simplicity, the survival of the simplest process. And how might you do this? Thinking about the dependability of your systems, rethinking the number, the density, and the complexity of the interaction and the moving parts of your delivery system. Because if you simplify it, you might eliminate opportunities for systemic failure. Makes things simple, easy. Subtraction. Services that reduce workload restore agency because you don't have to spend all your day trying to figure out how they work and how to get what you need. Restore capacity to patients, caregivers, and professionals so they have time, our most precious resource. Simplicity. Simplified service encourage clarity of purpose. You know what that is for. Ease of navigation and continuity of care. It's incredibly hard for organizations to make sure that my patient with diabetes, Sarah, meets with the diabetes clinician, Victor. It's much easier than some diabetes clinician meets with some diabetes patient. And it doesn't matter who they are. Both of them blur. Both of them blurry. The continuity of care with our organization, with our brand. Brands don't care, organizations don't care, technology doesn't care, people care. And so we need to make sure that the systems are simple so that people can come together and care. And civility. Services that are respectful to patients and clinicians. reinstate moral meaningfulness of the work that we do in healthcare. Get rid of all the stupid stuff that is there to tell you, we do not trust you. I don't think that patient has heart failure. You're upcoding. So we're going to have people come in over your shoulders and check that out. Disrespect for our professionalism. Disrespect that sometimes some of us have deserved. But the majority doesn't. The majority has shown up to care. And they're not getting, patients are showing up also for care, and they're not getting treated with kindness and respect. We need careful care, evidence-based scientific care for you. And we need kind care that respects who you are, the time, energy, and attention that you have, and recognizes that the purpose is you're living your life. Now, we don't have time for that. We have tons of people out there waiting for our services, and so we're overwhelmed. I think one of the problems that has led to this is that we have done something very bad in the way we're growing up as a humanity. We're valuing our independence. We're valuing our capacity to produce wealth, productive work. Now, meanwhile, care is necessary, but is rendered invisible, private, domestic, female. Most caregivers in the world are women. Most of them are women of color. Most of them are poor. Most of them are migrant. There's a crisis of care in the southern hemisphere because a lot of women have migrated to the northern hemisphere, as women in the northern hemisphere have actually joined the productive work, leaving care work to these other women. Why have we done this? And then the other aspect of it is that we've told people, you can't self-care. Your knee is hurting. You should get it checked right away. Could be something terrible. Go get checked. Grandmothers no longer feel they can talk about the health of their grandkids and provide advice. Is crying at night? And grandma is thinking, might be a colic, a tooth is coming out, maybe the diaper is call your pediatrician. So we disempowered and de-skilled people to take care of things. And so all the suffering now demands professional care, and there's not enough professional care to respond to all the suffering that we're all experiencing. So simultaneously, in our movement for care, as we try to get careful and kind care in healthcare, we need to work towards common care. And common care means that we look at the suffering and we realize that in our communities, in our families, with our friends, we have the capacity to care for and about and with each other. Yeah, there's a point that we may need professional care, but if somebody drops dead right now, there'll be, I hope somebody, at least one person here, but many more, that will come in and resuscitate that person, bring them from the dead. And if that happens in the street without any health professionals, there'll be somebody, lay person, that can do the same. If we can train people to bring people from the dead, we can certainly give people capacity to care for other people. And we do this. There are cooking shows and cooking books and cooking channels, and cooking for others is a way of caring for other people, to feed them. Now we've noticed, we've elevated that. We've given it glamour. We've made it a skill. People are proud. I'm going to show you my risotto. It's pretty good. Right? But where is the let me feed my elderly grandparent very slowly because he can't swallow show? How do I mobilize this person who cannot walk by themselves? How can I help this other person who seems to be having a hard time, in shopping in where are those basic skills? Without making sure that everybody can care, we are all going to be warehoused in nursing homes and cared by bots, like Baymax, like the inflated guy, Is that what you want to get old for? To be cared by a machine alone because your family is too busy making productive work? So we have a major crisis of care, of human care, of common care. And we need to make sure that we democratize care. Let's stop pretending that care is something that should not be rewarded, should not be recognized, should be hidden, should be domestic. We should make sure that care is distributed justly and is not just the work of women. Everyone should care. As an extension of that, we need to commit to caring for our communities. Our communities have been decimated by hate, attacking at the same time as this virus. Our communities are broken, our families are broken, our own professional communities are broken, and we're all suffering. And I think one of the ways out is to renew our commitment as humans to care for and about each other. When the lights went out, March 2020, pandemic is here, our collective response was not flight and fright and all that. Our collective response was to tend for others. Mutual aid exploded, people stayed in their homes, people started sewing masks, and all sorts of things. Students in Minneapolis started caring for the kids of the nurses that were sent to the front line without adequate PPE, and they were afraid of coming home and infected their kids, and the students went there and took care of the kids. We did that. That is in our firmware. We are not, when the computer got rebooted, what came out was a program of solidarity. Now then our software, our operating system looked on, and all of a sudden we are selfish. So we know, we've seen it all. We all of us have seen it. We've witnessed our capacity for solidarity. We need to use that to help recover from the enormous loss that we've all experienced. Loss of life, friends, family, colleagues, co-workers, loss of opportunity, things that you were hoping to achieve and had to be suspended. The opportunity to grieve, not only yourself, but with your family, with others, having to suffer alone. So we have to care not only in healthcare, but in our communities. And we have to care for our environment. Just this week, there are, just in one country, there are more than 6 massive climate-related events. We have to make this world a world in which we can live better. That is what care is about. And we have an opportunity. We can actually role model that in the only aspect of human activity, in addition to education and parenting, where care is central, which is what we do every day. And what we have to do is create a movement for care in which healthcare is not done for greed, but for solidarity, not based on rules and regulations, but on integrity, not based on pursuing efficiency, but elegance, not for patients like this, but for this patient. It has to be minimally disruptive of people's lives and of people's loves. And as we do this, as we are joined with patients in this journey, we are sure to develop not only relationships of care, but oftentimes relationships of love. We are in the Patient Revolution trying to help create this movement for care. And in this really, really hard time, when we are ready to come together and make a commitment to care for and about and with each other and recover from the major loss that we've all suffered, I invite you to join this movement for careful and kind care for all. Thank you for your attention. I know it is super hot, so we'll try to keep the questions only to the easy ones. There's one, Eddie has one.
Thank you so much, Victor. That was awesome. The people talk about the pandemic of health caregiver burnout that we are living. You touched on it, but it's the thinking might be that it's hard to give compassionate, empathic care if we are burnt out as providers. Can you help us? Any thoughts or what can we do?
Yeah, I think there are other people in the room that can probably comment on this as well. But I don't know if, we can quibble with the word, whether it's burnout or just simple exhaustion. I think there is, some people haven't had a time. Because you see, we were going through one wave, right? And it's going to be okay on the other side, and we'll recover and regroup, and we never recover and regroup, and there's another one, and let's recover and regroup, and no way, there's more. There are procedures that have been delayed. Now you need to pick up that, and nobody has recovered or regrouped. And so some of it can just be plain exhaustion, right? So I think when we use burnout, and there are some places that have said, well, that's a problem of our human resources, so let's have a human resource approach to it. So what can we do to help the well-being of our clinicians, particularly those who are suffering the most? Let's do something to them. And I'm a diabetes doctor. I'm very familiar with this saying, oh, you are obese and you're hypertensive and you're diabetes. What are you doing wrong? And how come 30% of the population is doing the same thing? Right? And we try to respond to each person one at a time in this way without changing the conditions that are creating the suffering. Just like, I'm going to take it out of burnout so that it becomes more clear. We have a problem of also another epidemic of diabetes, right? And the epidemic of diabetes is, we need to go and treat the pre-diabetes. And what's the public health way of treating pre-diabetes? Identify one by one the people that have elevated blood sugars and refer them to coaching on lifestyle modification and so forth. My son was preparing for a colonoscopy. He has ulcerative colitis. And so he's not eating anything. He's like, drinking, singing, that was him pooping, and all that stuff. And so I'm trying to support him. Say, let's watch the basketball game. So we turn on the TV. I'm trying to distract him, right, because he's not eating. So turn on the basketball game. 1 commercial, 2 commercials. All for food. Yeah, eat chicken, eat burgers, eat pizza with a burger inside the crust. And like, Jesus, right? So and then we say, what's wrong with you? Why can't you regulate your appetites? And right? And I think we do the same thing by actually labeling the victims as having the problem. If you look at one of the most successful diabetes prevention interventions was to take people who live in poor quality housing, in low-income housing that is run down and poor and violent, and just moving them to housing that is better. There was actually a randomized trial of this. It was through a lottery. Some people got the voucher that came with a person that helped them move to a better place. Others just were told, you can move. And others got to stay, and it was a lottery. The people that were helped to move and moved had a much lower rate of obesity, of depression, and diabetes without a single weight loss drug, a new diet, or an antidepressant. The conditions of living are killing people. The conditions of working are not conditions that enable our talents. I mean, many of us who are in the clinic, we were selected because of our talents to do this work, because of our commitment to care, because of our professionalism. And then we're put in conditions where that doesn't happen. Burnout is the lightest of consequences. Some people are taking their lives. So we have a huge crisis, and the industrial healthcare is cruel to patients, but it's cruel to clinicians as well. And if we don't take care of the people that take care of our patients are not going to get care when they come through our doors. Easier question?
Yeah, it seems like with a lot of the challenges that we face, I wonder...
I have hearing aids, so you need to work a little harder.
I wonder if trying to solve the problem would be looking at sort of the ways of knowing of like indigenous people or people from collectivist societies where they're more sort of relationally focused and more focused on sort of this one health concept, sort of that intersection between animal health, human health, as well as the environment. But kind of what are your thoughts?
Yeah, I think you've seen right through my device, right? I think I've tried to make the case that this is not just healthcare. This is about caring for each other and caring for our land, right? Caring for our environment. Absolutely right. And who has that baked into their philosophy? You said, indigenous people, but not just indigenous people. Any effort in human culture that has led to some sort of spiritual or religious component has always had an integrative view, right? For the most part, we recognize we're part of something bigger than ourselves. We are dust, that goes to dust. We are part of this thing. And if some part of it is sick, we are sick. Now, the biggest influence on our well-being, because we are social animals, are other people. And our crisis of care, in addition to the environmental crisis and so forth, is fundamentally a crisis of people. And the fact that we have people who are profiting actively from keeping us divided is something that should make us, think about how do we get politically active. So one of the things that is in the magic trick that keeps us keeps us this way is the notion that being politically active is for other people. Right? It's not for us. Politics is for those people. And then you complain of those people, right? Because like the people that we're electing do not deserve to represent us, let alone tell us how to live. Right? And in part is because we are not stepping up to take those roles. So we have benefit from education, from an understanding of suffering, from all those patients who have told us their story. How are we using that to try to make this world better? That's another way. Another definition of care is to give a damn. And if you give a damn, then how do you become active in shaping the community that you have? So another invitation is to become politically active. I'm not saying you need to be partisan and contribute to the division. I mean to say become politically active so you can begin to bring true democracy, which is not the rule of the majority, but is the rule of dialogue, a conversation, of understanding our difference and figuring out how do we walk together, not without a chunk of us, not with exclusion. Commissioner has a question. I can get really close to you, but then it'll be a little weird. Okay, sir.
What about the situation in which underpaid doctors are seeing hundreds of patients in 2 hours?
Yeah.
And when you reflect on that, most of these patients are poor, in very poor living conditions, but they are suffering from some problem which these underpaid one doctors looking after 100 patients in 2 hours time.
Yeah. So, you know, Commissioner, I was thinking of places like my home country, right, like Peru, where I talk to my colleagues and they're seeing patients as a blur, right, less than a minute or two. And what's happening there is, there's like, why are you here? I have dizziness. Oh, here. Either a test or a drug, right? And I've now learned that the test of choice for dizziness is a lipid panel. Right? And so the only reason I know that part is because, of course, people from Peru send me an email saying, this is my cholesterol profile. How old are you? 19. Like, I don't care, right? I mean, right? So it is incredible, right? So what happens is you get the illusion of care. A poor person in my country can go and get private care. And they say, I'm going to get an ultrasound because I think my liver is hurting. And they go to a place where there's somebody with a microphone connected to a TV that is not on any TV station. And they go, oh, you have stones. And then let me print that out. And then they print this, you know, they have a picture from Google, you know, of a stone. And take this to the hospital, tell them you have gallstones, and give me, you know, 10 soles or whatever. So the private health care, when you're poor, is a scandal. Turns out the private health care when you're rich is a scandal.
I'm going to do a stress system, maybe a CT angiogram with a coronary calcification. We'll do an angiogram just in case. We'll do this, an MRI, make sure the heart muscle is good. We'll look at the fat distribution on this. We'll do a fat aspirate biopsy. Why don't we just, I mean, we're there already. Why don't we just look at the quality of your bones and we figure out, I mean, you're executive, right? You want to live forever, so we'll work on that as well. And it's going to cost you $1 million, right? And then, of course, are the people that don't get access at all. And the people that get the illusion of access to our academic medical centers or other facilities, and they just have incompetent clinicians, overworked, cramped conditions, no care. So I think we have a crisis of care. I think it manifests in a number of dimensions, in global warming, gun violence, interpersonal difficulties. But in our professional lives, we have a duty to make sure that those systems recover in some way. Common care is one approach. More investment in healthcare, less corruption of the other kind in our systems. So when I wrote the book, it's mostly about Peruvian stuff and US stuff. And all of a sudden it sells well in Australia, and it sells well in Canada, and it sells well in the UK. The first translation was in Italy, the second one in Spain. And these are all systems with publicly funded healthcare. So what's the story? Part of the explanation is it's a cautionary tale. We don't want to go there. But part of the story is that there's a final common pathway related to care. If you do not invest enough, so policies of austerity, for instance, has done this in many places. If you don't invest enough,
or if you have people taking too much out of it, either through methods of profit seeking or corruption, people are stealing, the final common pathway is that you do not have resources to care for people. And if you recognize that the whole purpose of the system is to care for people, you have a massive scandal of misuse of public resources and misuse of public trust. It's too hot. I think the next conversation should be at the garden tonight. Thank you very much for your attention.